Well, good afternoon, everyone, and welcome back to the African American Myeloma Chapter. We're so privileged to have myeloma specialist, Dr. Craig Cole from Michigan State, here with us today. For those of you who are new, welcome. We're happy to have you spending the time with us here today. I'm Valerie Trainham, the African American Myeloma Community Chapter Head. Today's event is going to be recorded and sent out to all the registrants within 28 to 48 hours after the completion of the event. Because it is a Zoom meeting, we're going to be sharing this video publicly. Your names and faces will not be seen within the recording. Now, I want to start by thanking our sponsors, without whom this event would not be possible. AbbVie, Bristol Myers Squibb, Amgen Oncology, Genentech, Karyopharm Therapeutics, Oncopeptides, Adaptive Biotechnologies, Takeda Oncology. Now, as I say, our special guest today is Dr. Craig Cole. Dr. Cole is a board-certified hematologist who received his Bachelor of Science degree in physiology at Michigan State University and the College of Lyman Briggs in East Lansing, Michigan. Dr. Cole went on to receive his doctoral degree at the Ohio State University College of Medicine in Columbus, Ohio. He completed his internal medicine residency and hematology oncology fellowship at the University of Michigan Health System in Ann Arbor, Michigan. Dr. Cole subsequently had a post-fellowship laboratory research position at the Jerome Leiper Multiple Myeloma Center of Medicine at Dana-Farber Cancer Institute in Boston, Massachusetts. This opportunity then led him to become an attending hematologist at Gundersen Health in La Crosse, Wisconsin for 9 years. There he was an for both the medical and nursing schools of the Western campus of the University of Wisconsin School of Medicine and Public Health. He also served as affiliate faculty of graduate school medicine and public health. He then returned to the University of Michigan Rogel Center in Ann Arbor, Michigan, as an assistant professor in the Division of Hematology Oncology, with his primary clinical and research interests being in multiple myeloma. In May of 2019, he returned to Michigan State University College of Human Medicine at Breslin Cancer Center as the Director of Clinical Research in Hematology, Oncology, and Multiple Myeloma. He is also the Associate Director of the Michigan State University Center for Bleeding and Clotting Disorders. Dr. Cole has been the onset primary investigator for over 30 clinical trials and participated in over 50 clinical trials in multiple myeloma and malignant hematology. He is published in national journals and presented his research at the American Society of Hematology and the American Society for Apheresis national meetings. Dr. Cole has won awards for his work in teaching, multiple myeloma research, and patient advocacy. He also has a strong commitment to the equity of cancer care, patient empowerment, and community education by working with several local and national patient advocacy associations. Dr. Cole, the time is now yours.
Well, thank you. Thanks, Valerie, for the introduction, and thank you to the myeloma crowd for inviting me, and I really applaud them for having the African American myeloma community, bringing them together. It has been a dream of mine to have something like this for, gosh, decades now, and so I'm honored to speak for you today. So let's start, and I'm going to share my screen. and start my talk. The outline for what we'll talk about today is a brief what myeloma is. We'll talk about race and ethnicity in myeloma, talk a bit about the epidemiology and the differences of African Americans with myeloma, and some comparisons and some new data that we have regarding African Americans and the biology of myeloma. Then we'll talk about making the diagnosis and, importantly, discussing knowing your labs, the staging of myeloma and the risk biology. Then we'll turn our attention to treatments and talk about the tools of the trade, induction, transplant, and maintenance therapy. And then we'll talk about the exciting new data that we have on new upfront induction regimens using antibodies. Then we'll talk about the new therapies for relapsed myeloma and why clinical trials are so important to people of ethnicity. So in brief, I think everyone here knows that myeloma is a cancer of the plasma cells, and that myeloma cells and normal plasma cells are very dependent upon the bone marrow space. And when those cells become malignant, as any other cell can become malignant, those plasma cells, when they're malignant, we call myeloma, and they'll produce excessive amounts of antibody that we call the M protein, or myeloma protein, or the paraprotein. It gives us an idea of how much disease there is. It's the second most common blood cancer behind the lymphomas. 32,000 cases were estimated to have been diagnosed last year, and 131 persons are living with myeloma in the United States at this time. And myeloma is a disease of adults. I used to say older adults until I got into my 50s. And the median age between 65 and 74 years. And we'll talk about that in a bit. Here is some of the SEER data from the National Cancer Registry. And I think that you can see that myeloma overall has a higher incidence in men than in women, but especially in African Americans, that the number of cases of African American males is 16.5 per 100,000, and for African American women, 12 per 100,000, compared to the usual 8.8 and 5.7 in the general population. If you look at the overall population of myeloma in the United States, the number of Blacks and African Americans with myeloma is higher than the national number of African Americans, because the disease is more prevalent, has a higher incidence in African Americans. Blacks have twice the incidence of myeloma compared to twice. This is a bit older SEER data, but this is overall between men and women, that Blacks have overall a incidence of 11 per 100,000 as compared to all races at 5.8, Hispanics 5.2, whites 5.2, Native Americans 4.9, and people of Asian descent at 3.2. So there's significant disparity in the incidence of this disease. And with Blacks around the world having the highest risk of multiple myeloma of any ethnic group on the planet. And because the disease increases as people get older, that African Americans at the age of 80 have almost 80 per 100,000 of incidence. So it's much higher, and the rise is much steeper in older persons of African descent. So why is that? Well, there's no conclusive evidence that myeloma is an inherited disease. There are multiple studies trying to elucidate this, and it appears that the incidence is closely related to the increase in MGUS. We'll talk about that when we talk about MGUS. The racial difference cannot be explained by tobacco, alcohol, or socioeconomic status. Obesity does increase the risk, but obesity is not linked specifically to African Americans. That obesity increasing the risk of myeloma is independent of African Americans, or independent of the risk with African Americans. We do know that some occupational exposures are somewhat related. Ionizing radiation, and also chemical exposures over long periods of time, but really don't know how people get myeloma. And still is a very, very active area of research. And why is it so different between the races is still a very, very, very important and active area of research. One thing we do know is that between men and women, the incidence of myeloma, both Black men and white men, have been increasing, while the mortality of myeloma over the past 20 years has been decreasing, which is, of course, excellent news. Also, for African American women and white women, that again, the incidence has been climbing while the mortality has been declining. And I think that you can see that pretty much the decrease in mortality has pretty much kept in step with each other between the races. But we'll talk a bit about that later on in the talk. African Americans do appear to have biologically different disease. And we can see that by a number of different hints. African Americans usually present with myeloma at an age 4 years younger than their Caucasian counterparts. African American patients with myeloma will present with higher LDH. That's a chemical that's released while the myeloma cells are dividing. And if they're dividing rapidly, or if there's a lot of disease, the LDH would be higher. So the idea is that African Americans come in with a higher proliferative disease or higher disease burdens. One important thing is that African Americans appear to have more translocations of the 1114. And we'll definitely zero in on that regarding the new drug venetoclax in clinical trials. Also, 1114 is one of the standard risk, if not favorable risk, of mutations in myeloma. Also, that African Americans are less likely to have the very high risk lesions, mutations in myeloma that involve the chromosome P or the P53 gene deletions. There was a recent study that was done through the VA system through the VA system, everyone gets the same therapy because they're all covered by the same insurance. And when you look at African American outcomes, that African Americans have the same, if not better, survival than their Caucasian counterparts, in part due to that risk, but also due to biology that we're still trying to figure out. So what about labs? Well, as you know, that we check a number of labs on a regular basis and at the time of diagnosis for myeloma. We have the CBC, which looks at the red blood cell white count and the platelets, the comprehensive panel, which measures the calcium and creatinine or level of kidney function and bone status. There are two tests that are used for staging and usually they're done once or twice during a myeloma patient's time of disease. The beta-2 microglobulin tells us an independent way to say how many plasma cells are there in the body. And because that chemical is metabolized by the kidney, high levels may suggest either lots of myeloma or poor kidney function. And the LDH I talked about gives us an idea of the extent of disease and how rapidly the cells are producing. And then there are the protein tests that really tell us how much myeloma there is. So there's a protein electrophoresis, which looks at that M protein or that paraprotein produced by the myeloma cells. And that gives us an idea of how much myeloma there is. And when the treatments are being done, if that number goes down, then we're sure that the amount of myeloma is going down. We also have the immune fixation, which tells us the type of protein between IgG or IgA or kappa or lambda. We'll talk about that in a bit. Then there's a serum free light chain measurement that for some patients, the myeloma cells will only produce light chains. And that's another way, it's a correlate to the M protein to tell us how much myeloma there is. Then there are the urine tests that we've been doing for about 150 years to detect myeloma in the same way that the higher the protein, the more myeloma there is. And that's the Bench-Jones protein or the Bench-Jones quantitative protein. But the main tests are the SPEP, immunofixation, and the serum light chains. So a bit about the SPEP, that if we were to separate the plasma into its different components, we would have a graph much like this. We would see the albumin and then alpha and beta waves. But in that gamma region is where all the antibodies sit. And normally there are lots of different types of antibodies, so that gamma region has a broad hump. However, if there are clonal plasma cells or mutated plasma cells that only produce one type of monoclonal protein, then you'll have a high church spire peak. You'll have lots of protein that's of identical molecular weight clogging up one area of the protein electrophoresis. And that tells us how many, that's the monoclonal protein, and that gives us a correlate of how many myeloma cells there are. So instead of doing bone marrow biopsies every month that no one would ever like to have done, we do a bone marrow biopsy once, correlated to the amount of protein in the blood, the M protein, and then as we treat the myeloma and the plasma cells go down, the protein goes down. That's why it's critical to know the protein level, because it tells you that the treatment is working and when to celebrate that you've responded. If serum-free light chain is another way, and sometimes the main way of measuring the myeloma protein. And normally our bodies will produce equal amounts of lambda and kappa protein in the bloodstream at very low amounts. And when you look at the ratio between the kappa and lambda proteins, they should be about 1-to-1 or about equal. However, if we have plasma cells, malignant plasma cells producing only one type of protein, in this instance, the kappa light chain, it will suppress the lambda light chain, and then you'll have a ratio that's well out of whack. And the amount of kappa light chain or lambda light chain is correlated to the amount of disease. In the same fashion that with treatment, the kappa protein goes down as the myeloma goes down, and then you restore the other light chain, and the ratio is restored at 1. And that's also a time to celebrate. Most patients, about 80% of patients, their myeloma will produce a heavy chain and a minor light chain, IgG kappa or IgG lambda, or IgA kappa or lambda. There are other ones such as IgD and IgE, which are very rare. 20% of patients will produce only light chains. Their myeloma cells will be mutated and only be able to produce light chains, where the intact or the M protein won't give you the main number, the light chain will. And unfortunately, sometimes those light chains can get stuck in the kidney, causing renal insufficiency. Rarely, 2 to 1% of the time, you'll have myeloma cells that are so mutated that they're unable to produce any protein. And those are the non-secretory myeloma patients. And we have to measure their disease through other. So how do we make the diagnosis of myeloma? Well, conventional x-rays will show us bone lesions in about 75% of patients. But these days we really, and this is what a bone x-ray looks like, showing those lytic lesions or those areas of the bone that have been softened by the plasma cells. Now we use a lot of PET scan. PET scanning will light up in areas of bone turnover and myeloma activity that is more sensitive than the conventional x-rays that we've been doing for 100 years. And it's now one of the preferred ways of measuring bone disease and myeloma. And the diagnosis is confirmed by doing a bone marrow biopsy. And the normal amount of plasma cells in the bone marrow is 1%. So if you have 10%, that's concerning for myeloma. And with the addition of other features, they diagnose myeloma. So there's MGUS, which is the precursor disease. All patients with myeloma at some time in their history have had MGUS. That's when the protein is very low, the number of plasma cells in the bone marrow is very low, and of course there's no symptoms. And the risk of turning into myeloma is relatively low, about 1% per year, and that risk slowly climbs over the years and decades, very slowly. Some patients that have MGUS will turn into smoldering myeloma. That's when the protein level is higher and there are more plasma cells, greater than 10% plasma cells in the bone marrow, but there are no symptoms or high-risk features. And smoldering myeloma is a higher risk. It's closer to myeloma, so there's a higher risk of it turning into active myeloma, about 10% per year. And then true and true multiple myeloma is when you have malignant plasma cells seen on a bone marrow biopsy or any biopsy of a plasmacytoma, plus having one of the CRAB features. And those CRAB features being C for elevated calcium levels when the myeloma cells are causing bone destruction, releasing calcium into the body, R standing for renal insufficiency or kidney disease where the kidneys aren't functioning well, A standing for anemia where the bone marrow has been taken over by the plasma cells and you're unable to make adequate numbers of red blood cells, and the B being bone disease where there are lytic lesions seen on either conventional x-rays and, as I mentioned earlier, these days using CT scan or PET scan. Just in 2014, the high-risk serologic features or myeloma-defining labs were included in the diagnosis of treatable myeloma, and that includes when myeloma patients have greater than 60% plasma cells. So if they have lots and lots of plasma cells in the bone marrow, the risk of having one of the CRAB is so high that we treat. When their serum free light chains is so high, when their ratio is over 100, again, there's a 90% chance that they'll have one of the CRAB features in a couple of years. So we treat those people to avoid those problems. And if there are 2 lesions on an MRI or PET scan that are seen, again, those patients have a very high risk of having progressive disease and having one of the CRAB criteria or one of the CRAB symptoms, and we avoid that by treating those patients. So we monitor for changes in MGUS patients, we closely monitor smoldering myeloma patients, and we use induction therapy at the time of diagnosis for myeloma, either with the high-risk features, now called slim CRAB features, or true and true. One question that came up today when I was talking to a patient about family risk is that it's true that the higher risk of multiple myeloma in Blacks is primarily due to the higher risk of MGUS. And so we do know that myeloma patients, that their siblings have a higher risk of not necessarily multiple myeloma, but higher risk of having MGUS. And MGUS rarely, 1% per year turns into myeloma. So is myeloma hereditary? The true and true cancer isn't necessarily hereditary, but MGUS, its precursor lesion, can be hereditary. There is no data, in fact, this has been looked at a number of times, suggests that Blacks have any increased risk of progression from MGUS to myeloma in any other race. So that 1% per year applies to all races. But it is the higher incidence of MGUS in African Americans that relates to the higher numbers of myeloma that we see in African Americans. The staging for a myeloma, when we do that bone marrow biopsy, one thing we want to do is what are the mutations that cause this disease in the first place? So we do those FISH cytogenetics. And when we look at the mutations that cause the myeloma in the first place, people are broken up into 2 different groups, either standard risk myeloma, where it is easier to treat and the time to next treatment is much longer, and high risk myeloma, which is more difficult to treat, and the treatments don't last as long as they do with standard risk patients. And again, as I mentioned earlier, some of the high-risk features are rarer in African Americans. And the 1114 translocation is more common in African Americans. So once we get all the data back, then we stage patients. Stage 1 is when patients have a low beta-2 microglobulin, meaning they don't have as many plasma cells. The LDH, the cells aren't dividing very quickly, and they don't have those high-risk cytogenetics. As opposed to stage 3, where they have lots of beta-2 microglobulins, suggesting either kidney problems or lots of disease. The LDH is a bit higher, meaning the cells are dividing a bit quicker and the number of cells is higher, and or the high-risk cytogenetics that I talked about. And stage 2 means that it fits somewhere in between. Again, African Americans are more likely to have high LDHs than other ethnic groups. So the Iceberg model, which is a model I love for myeloma, and I talk to my patients about goals of therapy. That once we made the diagnosis, what are we trying to do? What we're trying to do, of course, is to get rid of the symptomatic myeloma so that it's below the water. So when you walk down the street, people can't see that you have myeloma, that is hidden beneath the waves, and then to drive the disease as low as possible, as deep into the water as possible. A partial remission when the M protein is cut into half. A complete remission is when we can't see any M protein at all in the bloodstream. And minimum residual disease is when, on very sensitive testing, that we can't find one myeloma cell out of 100,000 normal bone marrow cells. And so the treatment is usually to reduce the protein as low as we can, if not completely gone. Because myeloma is not curable at this time, that people will have progressive disease, and that's when the protein goes up again by 25%, or they develop symptoms, and that's when we use a second treatment, a salvage therapy, and we'll talk about that in a bit. So how do we treat multiple myeloma in 2021? Well, we use science to treat myeloma. As you know, we don't use chemotherapy to treat myeloma. We use science. We use immunomodulatory drugs, or the IMiDs, Revlimid and pomalidomide being the most common. We use a proteasome inhibitors such as Velcade, Ninlaro, or Kyprolis. We'll talk about that. And we use antibodies against myeloma, immunotherapy, Darzalex, Saralessa, and Implicit. There are new drugs. We just had a drug approved just a couple weeks ago that are also based on science as a way to treat the disease. So we'll talk about frontline therapy, maintenance therapy, and relapse therapy. But as you can see, there are a number of different regimens for induction therapy. I put for induction consolidation, maintenance, and rescue therapy. We'll start talking about induction therapy. So with Revlimid, or the IMiDs, how does that work? Well, as I mentioned before, it uses science. That we do know that Revlimid, pomalidomide, thalidomide do inhibit DNA of the myeloma cells just a little bit. So it kills the cells by decreasing the mechanisms inside the cell. And we do know that it does have a slight inhibition of blood vessels that feed the cancer, but primarily by decreasing the cytokines that make blood vessels. Decreasing those cytokines do harm the plasma cell, and they can't survive with a lot of those cytokines, more so than surviving without the blood vessels. One thing it really does is inhibits the bone marrow adhesion, the myeloma cell adhesion to the bone marrow stromal cells. Myeloma cells can't live without their bone marrow stromal cells. The IMiDs detach the myeloma cell from the bone marrow stromal cell, and then they die. They can't live without those bone marrow stromal cells. Also, it starves the myeloma cells to death. They need interleukin-6 in order to grow, proliferate, and stay alive. And IMiDs get rid of the IL-6 being fed by the bone marrow stromal cells. Myeloma cells starve to death. And then one fascinating way that these drugs work is they actually get the patient's own T cells to recognize and destroy the myeloma cells. So it activates the patient's own natural killer cells to rid of the disease. An amazing drug. It started out with thalidomide in the 90s, which then led to Revlimid and pomalidomide in 2006 and 2013. Iberdomide, or CC220, is in late phase clinical trials with incredible activity. And the cell mods, including 92480, is in incredible early phase clinical trials with incredible activity in highly refractory and relapsed patients. Can't wait to see what happens with that. With pomalidomide, the proteasome inhibitors has a different mechanism of action. It really uses that protein metabolism of myeloma cells against it. So the proteasome is a little organelle found in all cells, but really in myeloma cells. And you know, what do myeloma cells do? They produce lots of protein. They produce signaling proteins, receptor proteins, and M protein. And when those proteins get degraded, or when they have served their function, they go to the proteasome, which acts as a garbage disposal, chews up the cells and spits out, chews up the protein and spits it out. However, and myeloma cells produce tons of protein. The proteasome inhibitors put cement in the garbage disposal of those plasma cells, which is like putting a cork in the exhaust pipe of those plasma cells. So now all of that protein is made by the myeloma cells build up, which means they can't hang on to those bone marrow stromal cells. They can't use their normal function, and they blow up, using their own protein against them to kill those cells. And the proteasome inhibitors, again, in 2003, Velcade came out, and again is one of the main treatments that we use for induction therapy for myeloma. We then in 2012 had carfilzomib, an irreversible proteasome inhibitor, and ixazomib, the oral version of Velcade, another borinated proteasome inhibitor, which was approved in 2015. So in treating newly diagnosed myeloma, we usually assess patients if they're transplant candidates or not transplant candidates. After we assess if they're transplant, non-transplant candidates, we then say, is this a high-risk person with those high-risk features and high stage that I talked about earlier, or is there standard risk? And that risk is primarily made on those cytogenetics that I talked about, the 17Ps, the mutations, MP53, the 414s. For those folks, we use VRD induction therapies, or sometimes daratumumab, I'll talk about in a bit, with Revlimid. For non-transplant standard risk patients, again, we use triple therapy, the VRD, which I think is very well tolerated even in older non-fit, non-transplant candidate patients. That's continued for 12 months followed by maintenance therapy. For transplant candidates, for patients who and really, every patient I see, I really consider them to be transplant candidates until proven otherwise, unless they have significant comorbidities that prevent that. And again, we break them into high risk and standard risk patients. For the high risk patients, recently, and I'll show you the data, that we use 4 drug induction therapies, Dara RVD or Dara VRD for 4 cycles, followed by early stem cell transplant for the high risk group. So we have used carfilzomib Revdex for the high risk group also. For those patients that are standard risk, we at this time are still using and has served us incredibly well, Velcade, Revlimid, and dexamethasone induction therapy, followed by either early auto transplant after 4 cycles or continued therapy and delayed transplant. And then all groups go on a maintenance therapy. The high-risk patients go on a proteasome inhibitor-based maintenance, while standard-risk patients go on a Revlimid maintenance. Our preferred option and definitely the most common induction therapy that I do for my myeloma patients is VRD followed by early transplant. What I like to tell patients of how transplant works is that I don't know much about boxing, I'll be honest with you, but RVD in those first 4 cycles are like a right hand punch, and you punch and punch with your right hand. And then when the cancer and the myeloma is just getting kind of wobbly, the last thing it's expecting is that transplant, is that high dose single hit of chemotherapy that knocks the disease out. And yes, you can knock out the other guy with using your right punch, but the left hook is going to knock him out. And to prove that, there have been studies that show that left hook is very powerful in keeping the disease under control, the largest one being the IFM study, which got patients under the age of 65 in Europe that were newly diagnosed, and either had them get 8 cycles of VRD with transplant at the time of relapse, or they got RVD for 3 cycles, followed by an autologous transplant, followed by RVD for another 2 cycles, and everyone went on Rev maintenance. The caveat to this trial from 2009 was that Rev maintenance only continued for 1 year, and in the United States we continue it indefinitely until relapse, and that in Europe at that time there were limited regimens for relapse. And so most patients that relapse that didn't get transplant ended up getting the transplant as a way to control their disease when it relapsed. So over 76% of patients that were on the no upfront transplant arm ended up getting a transplant at the time of relapse. Therefore, this trial wasn't transplant versus no transplant, but was transplant upfront versus delayed transplant, because 76% of those patients got transplant at some point in the future. So the results of that trial is that RVD versus upfront transplant for toxicities, transplant had more toxicities. However, those toxicities occur in the hospital and are controlled by the staff that has been doing transplant for now, 25 years, 30 years we've been doing autologous stem cell transplant for myeloma. So it's a well-worn path on how to control those toxicities. The most important thing is the time to relapse. That for these patients, it took longer for the myeloma to come back with a transplant than without the transplant. And this data is with only using Rev maintenance for 1 year. In the United States, likely these numbers are longer because we have patients on Rev maintenance much longer. So longer time before the disease came back. The overall survival was the same, and the reason why it was the same was because most patients got transplant at the time of relapse. So that told us that yes, you can delay the transplant until first relapse, but still, and you still get the benefit from having transplant even if you don't have after 4 cycles. Depth of response, how deep you go on that Iceberg model, transplant wins for that. Again, the bad guy gets knocked out and stays down deeper on that Iceberg model. And negative MRD, that I can't find one myeloma cell in 100,000 normal cells inside the bone marrow. Those depth of that deep responses, transplant gets you that too, which is why I recommend stem cell transplant strongly for my patients. And that negative MRD was a strong predictor of that it took a long time for patients to relapse and their overall survival. So based on it took a long time for patients to relapse and deeper responses is why I always recommend transplant. One thing that I have my colleagues and I have patients definitely cognizant to is that African-American patients are less likely to receive stem cell transplant than white patients, even after controlling for age, gender, socioeconomic status, insurance provider, and comorbidity score. And when looking at that, sometimes that the provider of African-American patients don't offer transplant. So if a doctor doesn't offer you transplant, a second opinion, make sure you seek those out. Seek out second opinions and definitely seek out stem cell transplant because you want to have that on your side. What to do after transplant? Well, there was one of the largest studies in the United States for myeloma patients to answer that. So after patients had gotten induction therapy and went to transplant, the question was, is it better to, after transplant, to go straight to Rev maintenance, or should we do consolidation, another 3 or 4 cycles of RVD after transplant, just like the IFM trial, or should patients get a second transplant, a tandem, another transplant after their first transplant? And that question was answered by this study, and the answer was it didn't make a difference in time to relapse or overall survival for standard risk patients if you got 2 transplants, consolidation, or maintenance therapy. So the easiest thing is that we go straight to maintenance therapy. Is a question if high-risk patients would benefit from 2 transplants. I still think they were looking into that a bit, but now for standard risk patients, after transplant, people just go straight to maintenance therapy. For Maintenance therapy, there have been 4 randomized trials that have shown that Revlimid maintenance versus no maintenance shows superiority and progression-free survival and some overall survival improvement. And in the graph below are all the studies that have looked at this, and basically all of them show that there is a benefit in both progression-free survival and overall survival in being on Revlimid maintenance. We strongly recommend Revlimid maintenance for all patients, but we don't know how long we should continue it. And the studies looking at other maintenance therapies. From the Stamina trial, there was a recent update that was at the ASCO 2020 meeting, where patients that were in that trial, where they either went to direct to Rev maintenance or consolidation or tandem transplant, patients were given a choice if they wanted to stop the Rev maintenance after 38 months or if they wanted to continue on. And what we found out, and you can see the curves where they split. And with these probability curves, the higher bar is the better outcome. The lower bar is the worst outcome. And those patients that stopped Revlimid at 38 months electively did relapse earlier than those that continued. Yes, the ones that continued on, there were some relapses that occurred at that time, but less so than those who stopped Rev maintenance. So we're still looking, so now we know 36 is the very least. Indefinite is until relapse is preferred, definitely. And with my patients, we continue Rev maintenance until time of progression. And we'll see the future studies if it'll give us a better idea of when we should stop Rev maintenance. So to talk about the antibody therapies on those plasma cells that we talked about, on those myeloma cells, there are lots of proteins which identify the plasma cell as a malignant cell in the body. There's SLAM7, CD40, CD138, CD38 are all proteins that help identify a myeloma cell as a myeloma cell. Because our bodies don't produce antibodies against myeloma cells, those proteins have been made, those antibodies have been made in the lab. Anytime that you have an infection, your body makes an antibody to it. Your body doesn't make antibodies to myeloma cells. We made it in the lab. The antibody against the SLAM7 protein on myeloma cells is called elotuzumab. And the antibodies against CD38 are daratumumab and isatuximab. And then there was a recently discovered protein called BCMA, or B-cell maturation antigen, that's on cells. And the recently approved blinatumomab is against BCMA, as well as the CAR T therapies and the bispecific antibodies that we'll talk about at the end of my talk. And those are, again, directed towards BCMA. So, and just to show you, at the very bottom of this graph are all the different organs in the body, and on the y-axis is is BCMA, and you see BCMA is only located on those plasma cells. Very low amount of BCMA in other cells. So these antibodies are very, very, very specific to the plasma cell. They are plasma cell hunters that hunt down those plasma cells and leave the other cells alone, which is what we want for any cancer therapy. So how do these antibodies work? Well, one thing that they do is that there's that antigen, that, let's say, CD38 on top of the myeloma cell. And when those antibodies are given IV, they attach to the myeloma cell, and then they call in the immune system, the good guy white cells. That go in and fire granules at the plasma cells and kill them dead. So they go shoot out. There's a shootout in the bone marrow where the white blood cells destroy the plasma cells based on the signal from that antibody. Also, those T cells that we talked about with the immunomodulatory drugs, when those antibodies are attached to the myeloma cell, those antibodies then call in those T cells, and they come in, they destroy the myeloma cell in hand-to-hand combat. also an ancient part of our immune system called complement, which bores holes in the proteins in the cell membranes of cells. Those attach to antibodies. When complement attaches to antibodies, it calls in the complement cascade, and those bore holes in the cells, which also kills them. Also, interestingly enough, when these antibodies attach to the myeloma cells, they cross-circuit the signaling pathways inside the myeloma cell, which kills them. And also, because the antibodies attach to the myeloma cells, they make the bone marrow stromal cells detach the myeloma cell away, and without, and again, as I had mentioned earlier, without being attached to the bone marrow stromal cells, myeloma cells can't live. And so multiple mechanisms of action of how the antibody therapies work, which has 4 of them approved by the FDA at this time. Implicity or elotuzumab against SLAM7, which is approved for relapse refractory disease in combination with Revlimid pomalidomide. Daratumumab or Darzalex, either given IV, recently approved with the subcutaneous version called Darzalex Faspro. And it is approved for relapse refractory disease, but also for newly diagnosed myeloma in combination with Velcade, thalidomide, dexamethasone, or in combination with Velcade, methylprednisolone, or with Velcade and dexamethasone alone. And I'll show you some really exciting studies in using a Darzalex up front. Sarlissa, cetuximab, also approved by the FDA, also against CD38 like daratumumab for relapsed refractory myeloma. And then recently approved is blintanumab, which is an antibody drug conjugate. So that antibody attaches to the myeloma cell, and it actually has a payload attached to the antibody. When an antibody is brought into the myeloma cell via that BCMA that we talked about, that it unloads its chemical payload and only kills the myeloma cell. So an absolutely fascinating 2nd generation antibody that has been recently approved for patients that have received 4 prior cycles of therapy. For induction therapy, as soon as those antibodies were utilized in relapse therapy, we moved it up front. And look at, I mean, this is a busy graph, but incredible responses, overall responses in the 99-100 range. And one study I'd like to draw your eye to is the Griffin study of daratumumab RVD versus RVD alone. And with that study in transplant eligible patients that were newly diagnosed, they were given either daratumumab and RVD or RVD alone. And the addition of daratumumab to RVD had a significant improvement in those really deep responses and those complete responses and depth of response. So those patients that received the Dara RVD and at the end of their consolidation had deeper responses than RVD alone. And the addition of daratumumab did not preclude a stem cell harvest, but we do need to get more information. This trial is very, very exciting in showing depth of response, how deep you can get on that iceberg. The question is how long do those responses last in comparison to RVD? But because of the depth of response and how important that is for very high-risk patients, we are tending to use RVD with daratumumab for high-risk patients. For standard-risk patients, we need to get more data on progression-free survival. With the typical course of myeloma is that we have patients that are newly diagnosed, they have the highest protein that they'll ever have, and we do the induction therapies that RVD, maybe a daratumumab, including a regimen, stem cell transplant, and really pull down that protein level as low as it can go. And then there are maintenance therapy. And hopefully that's for a nice long time. However, at some point, and that's the first line of therapy, at some point that myeloma protein will start to rise. And that's why it's important to know your protein. And if that protein is going up by 25% from this lowest limit or by 0.5, then you have to worry, is the disease returning? And usually we watch very carefully when we see patients are relapsing, and if they're meeting those criteria. And the trick is that you want to intercept the disease before it starts causing a lot of problems. And so when we confirm that the patient is relapsing, again, we want to intercept it before those crab symptoms hit, and we start a second line of treatment. And that second line of treatment will bring down, these days, incredible second line treatments, bring down that protein once again, hopefully for a long time. And then and that's the second line of therapy. Then the disease may come back, and that can go for different lines, different treatments for second, third, fourth, fifth line of therapies. And what we call relapse refractory therapy is when we do a fourth or fifth line of treatment and it doesn't work. The disease continues to grow despite that. And that's where we have all of our new science, our newest clinical trials are there to beat down the disease, to destroy refractory myeloma before it gets too bad. One important point is that most patients, when they have relapse, will relapse only with the M protein going up. But one thing to be very cognizant of is that 30% of patients will have symptoms related to their relapse. So if your protein's going up and you're having pain or symptoms, definitely talk to your doctor about changing therapies. And a lot of those symptomatic relapses will be lytic lesions. And so when I have a patient that is relapsing biochemically with increase in their protein, I am sure to get another PET scan or imaging study to assure that they don't have any bone disease. Because if I'm watching and waiting and seeing it and trying to confirm if the relapse is happening, I need to jump all over it if it appears that they have new bone disease. For relapse myeloma, on Revlimid maintenance, there are a number of different therapies. Our go-to is frequently Darapomdex, Elopomdex, or Isatuximab Pomdex. For relapse off Velcade, again, a number of different therapies. I put some of them in bold on the relapse after Velcade, first relapse after Velcade. And then for those patients that weren't on maintenance, then there's basically an open playbook of different therapies that can be used. And it's important to have a conversation with a doctor about the different therapies. Some of these are all oral, some of these are IV, some of these require lots of visits, some of these don't require very many visits at all. And I would always encourage clinical trials. It's a very, very important component is clinical trials, because that's where the newest therapy is. For a second line therapy or later relapses, again, a number of different therapies, including multiple therapies that have been approved by the FDA just in the past 12 months, including Darzalex, Faspro, Isatuximab, Blinnerap, and just recently, a couple weeks ago, was approved Melfufan. And again, those therapies wouldn't be available if there were no clinical trials. So I always recommend clinical trials. And unfortunately, I have, because of the number of clinical trials and the number of different therapies, I have not had to reach into the chemotherapy realm very much. In fact, I can't even think of the last time that I gave chemotherapy for relapsed refractory myeloma, because all the new therapies work so well, and there's always clinical trials available. So let's talk in the next few minutes, remaining few minutes, let's talk about the new stuff. And one really important new breakthrough, I would say, is in myeloma medicine is the role of precision medicine or biomarker-directed drugs. And so in the little cartoon above, myeloma patients are very different from one another. They have different mutations causing their disease. What if we could target just that mutation that is occurring in a patient and have that work for that patient? Targeted precision medicine, designer medicine for multiple myeloma. Well, we have that today. This is a typical myeloma cell. And when those cytokines attach to the myeloma cell, they turn on a number of of different signaling pathways, which include the activation of a protein called BCL2. And all those pathways with BCL2 just helps to keep the myeloma cell alive. A lot of those other pathways also cause the myeloma cell to proliferate, differentiate, and act aggressive, but they also use BCL2 to keep the cell alive. For those patients that have the 1114 translocation, that BCL2 component looms much larger, and the cells are much more dependent on that anti-apoptosis or pro-survival switch. That BCL2 switch keeps those myeloma cells from dying. They're dependent on that switch. What happens is as they slowly divide, they won't die and they just build up inside the body. Well, what if you could turn off that switch that keeps the myeloma cells alive? What would happen is that without that switch, there's nothing to keep them alive. They just fall apart and they fade away. Without that BCL2 switch that is overexpressed in patients with 1114 myeloma, and it targets just those cells with the 1114. And there was a study that was done in 2017 where they gave venetoclax, a BCL2 inhibitor, to patients with myeloma. The response rate overall for all patients was pretty modest, 21% response rate, and not very good deep responses. However, in patients that had 1114, it doubled the response rates. The biology actually worked. And it did not work in patients that didn't have 1114. And if they had that high BCL2, if those 1114s were making lots and lots of BCL2, those cells were especially sensitive to venetoclax. 88% response rate. That BCL2 translocation 1114 myeloma patients, which then led to that combination being trialed in a trial called Bellini. The Bellini trial was a trial that was recently published and conducted, and it was a double-blind randomized trial where patients either got Velcade, dexamethasone, very good second-line therapy, a third-line, first and second, third-line therapy, or they got Velcade plus venetoclax. So all patients got very good therapy. One group of patients got the addition of venetoclax. And these were all patients. And so when you looked at the response rates, again, were pretty good. That the progression-free survival was extended in those patients that got the venetoclax and Velcade, but not a lot to write home about. However, and that's in all patients, but when you looked at the patients that had the 1114 translocation, look how much higher that blue line is. That a lot of those patients were not relapsing at the rate as the red line. The patients that were just getting Velcade and placebo alone. So progression-free survival, much better for the 1114 patients. And as I mentioned earlier, African Americans have a higher incidence of the 1114 translocation than other ethnic groups. And there was definitely a survival benefit for those venetoclax patients who had, but only those that had the 1114 high BCL2. In this trial, the addition of venetoclax to Velcade improved the progression-free survival, overall survival, MRD negativity rates, but only in those patients that had 1114. For those patients that didn't have 1114, they had a tendency to get a lot of infections after they had therapy and had lots of adverse outcomes, again, attributed to infection. So this therapy really is a designer therapy that is biomarker driven to the 1114 patients. And so now there are multiple clinical trials going on. Very excited about the inclusion of venetoclax to myeloma therapy. So the last thing I'll talk about are CAR Ts, because everyone's excited about CAR T. So how does it work? Well, T cells, we had mentioned before, are the white blood cells that attack cancer cells. Chimeric antigen receptors help those T cells find cancer cells. So It is a little signal that helps T cells seek out cancer cells. Well, what if we could program a patient's T cells to find and destroy the cancer cell? So not using Revlimid to kind of inch them over, not using an antibody to try and coax them over, but really have the T cells directed to kill the cancer cell. This is how it works. We harvest the T cells the same way we would harvest stem cells for a transplant. And then we get a virus, a lentivirus, a retrovirus, that is manufactured to have a chimeric antigen receptor gene inside of it. And what happens is that you incubate those T cells with that virus. The virus infects the T cells, and the only thing that the virus has inside of it is that chimeric receptor antigen gene. So that gene therapy works by placing the gene inside the T cells that weren't there to begin with. And those T cells read that DNA, reads that gene, and then that T cell starts to express a chimeric receptor antigen. So now that T cell is a cancer hunting T cell with the introduction of that gene. And now you grow those cells in culture, you get billions, millions, and millions of those CAR Ts that are now transfected, and you give it back to the patient. The bottom line is you get a T cell that's pretty humdrum. You infect it with the retrovirus that implants that gene inside the T cell, which turns on those CAR Ts, and the only thing they know how to do is kill cancer cells. So for myeloma, we have BCMA as our target, and we get those T cells, and we place that anti-BCMA chimeric receptor gene in it. And now those T cells want to hunt myeloma cells. And it takes about 9 to 14 days to incubate the cells. And altogether, it takes about 4 to 6 weeks to get the T cells manufactured. But once they're manufactured, they're infused into patients, and those CAR Ts, those cancer hunting T cells, go straight to the cancer and destroy it. And the good thing is that they should continue to grow inside the patient, giving an everlasting fountain of therapy where those T cells will constantly hunt down the myeloma cells. There are toxicities associated with CAR T therapy, including cytokine release syndrome, where patients can have fevers, sometimes pulmonary problems and blood pressure problems, and neurotoxicity, where they can have trouble speaking, understanding things, and can have seizures. And these are the results of some of the recent results of 6 of the recent CAR T trials. And their product names, they're all in pretty early phase clinical trials. They're primarily in patients that have lots of different therapies. They definitely have some toxicities, but the really bad cytokine release syndrome are only single digits. But the overall response rates are really quite incredible for these heavily pretreated patients. To have complete response rates of 50, 60, 70% is remarkable. The one trick about CAR T for myeloma so far is that this therapy doesn't last as long as we would like it to. Patients will have remissions for 1 to 2 years and then relapse. So we definitely have to be cognizant of that and trying to improve CAR T so it lasts longer. A correlate to that are the bispecific antibodies, where we get an antibody against a myeloma cell, we get an antibody for a T cell, and what happens is that bispecific brings the T cell to the myeloma cell, but this time the antibody makes the T cell angry, which again releases its granules to go destroy the the myeloma cell. So the BiTE antibodies are very exciting, very correlative to the CAR T without having to do a lot of the time spent in preparing it. And there's a lot of comparison between CAR T and bispecific antibodies because they're very close to each other. It'll be interesting to see how between these two, where they fit into myeloma therapy. So I'm going to end on clinical trials. In clinical trials, everything I've said earlier is really based on clinical trials and trying to find what's the best clinical trial, what's the best drug, and all of the things that have happened is because people have been enrolled in clinical trials. So people get lots of support. My patients on clinical trials get lots of attention, and we primarily look to assure their safety and to make sure that what they're on is doing them well. The FDA looked at approvals for myeloma drugs between 2003 and 2017, and disappointingly that there weren't a lot of African Americans and Blacks involved in those clinical trials. So how do we know that these drugs will work for African Americans? I think I've made some of the argument that myeloma cells are the myeloma biology is a bit different in African Americans. We need to know if those work. The median enrolled percentage of Blacks in clinical trials is 4.5%. It's a bit higher in the United States at 10%, but there were drugs approved for myeloma that only had 5% involved by African Americans. And some trials don't even mention how many people were involved in it. So we really do need appropriate representation in myeloma clinical trials to know if these drugs work equally for everybody. It's critical to know that. And you can refer to the sites of find clinical trials, including the Myeloma Crowd Health Tree, which can help find clinical trials near you. So, how do things get better for myeloma? Well, therapies all started clinical trials, and some of those early clinical trials with chemotherapy 40 years ago didn't have a lot of effectiveness and had lots of side effects. They became the standard of care, but every year, the clinical trials were getting better. They were getting less side effects and more effectiveness. And that's how things move along. That clinical trial replaces the standard of care. The standard of care is then replaced by a clinical trial, and on and on. And that then eventually will lead to a cure for myeloma. And I am so excited about all the new breakthroughs that have happened just literally in the past 3 months and over the past 12 months in myeloma. It is incredible, but I would definitely encourage you to be involved in clinical trials. Thank you.
Awesome. Thank you so much for that presentation, Dr. Cole. Awesome presentation. I always learn something when I hear your presentations. You always present something. So thank you so much. We really appreciate your help today. And as I said, we learned so much from the presentation. And I think it was just a timely topic for this chapter. Now we have been fielding some questions, in the Q&A box, and I think Audrey's been trying to help me get some of those answered there. So we're going to go. I think she's going to help me here. If you haven't already asked the question and you want to, just click on the Q&A box at the bottom of your screen. You may just hover your mouse around a little bit and it will pop up there. We're gonna go to that. Let's see. So we had some pretty good questions to come in. I know Audrey's answered some of them. So here's a question. Erica asked, I saw plasmacytoma on the bar graph that you showed, but missed the information regarding the treatment for that. So how is the plasmacytoma treated, Dr. Cole?
So if a plasmacytoma occurs singly, so if a patient has a single mass or a single area of plasma cells in a bone, or sometimes people can have plasma cells that are plasmacytoma or plasma cell mass that occurs outside the bone. If they don't have myeloma, so if they have just that mass, but they don't have any of the other biologic characteristics of myeloma, we'll frequently do radiation to that area. Rarely, sometimes people will have to have surgery if it's like in a bad place, like in the airway or on the spinal cord. But usually single plasmacytomas are treated with radiation. However, if a patient has a plasmacytoma, multiple plasmacytomas, in addition to having multiple myeloma, then you target the whole person. You treat the whole disease, usually with some type of either induction or salvage therapy for myeloma, myeloma. And if that plasmacytoma is causing pain, then sometimes the addition of radiation.
Okay. And we do have a couple in here in regards to transplants. Are more than one transplant still an option? I know you mentioned that with high risk, but are more than transplants still an option or not because of all the new medicines?
That's a really good question. They're all good questions, but one thing that left hook and the right hook thing does apply in later phases of disease, and so when that a patient, especially if they've had a long duration of therapy, from a long duration of response after transplant. So if a patient has induction therapy, gets a transplant, and they're on maintenance therapy for one of my patients, for a couple of my patients, for 8 years, and then they relapse, you really think about, that left hook really did work for a long period of time, that you can repeat that left hook again. And so frequently they'll obtain stem cells for 2, sometimes 3 transplants for that purpose of reusing that, because you can always use that left hook to drive down the disease, especially if it worked well the first time.
Thank you. This is a smoldering question. Are there any approaches other than watch and wait to see, to slow the progression of smoldering multiple myeloma?
Yes, that is something that we are looking at here at Michigan State. And we're building a smoldering group for that purpose. And I'm doing a lecture tomorrow on smoldering myeloma, so it's very timely. But for very high risk patients, meaning that their protein is going up and up and up, where it is inevitable that they're going to run into trouble, then that's when I think the addition of some type of therapy, Revlimid, or potentially full induction therapy to slow an inevitable, increase in disease. The one thing that we know about smoldering myeloma is about 75% of smoldering patients will end up with myeloma over the course of their lifetime, which means 25% won't. And what we definitely don't want to do is treat everyone at the expense of those 25% of patients who may never have myeloma. There have been some trials that have suggested that early intervention with Revlimid may slow down the progression. We're waiting to see if it does anything for overall survival. But what I would strongly encourage all of my smoldering patients to do is definitely be involved in clinical trials. We need to understand smoldering much better than what we do now. We really need involvement in clinical trials, especially understanding the biology of smoldering myeloma, and especially in African Americans.
Thank you. And this is 2 questions, but they're both pertaining kind of to our med that we love to hate, dexamethasone. So Jim asks, is dexamethasone, does it work the same as methylprednisolone? Prednisone, I think that's correct. Yep. And just say in that same kind of question there, is there anything that can be done to kind of reflect the side effects, the weight increase and the hair loss, increased facial hair, those things that come with the dexamethasone?
And that's a super question. And dexamethasone is something that we've been married to in myeloma for 50, 60 years now. And the steroids do have different potency. So methylprednisolone and dexamethasone are among the highest potency for steroids. We sometimes use methylprednisolone and prednisone, probably the lower potency one, for in addition to some of the oral therapies, and dexamethasone which kicks in a lot quicker. And methylprednisolone can kick in pretty quickly. It lasts a bit longer. So some of its differences in pharmacokinetics and pharmacodynamics, but basically what they all do is that they turn on that death switch inside the cancer cells. So it leaves the rest of your cells alone in the way of death, but it really does knock out those myeloma cells. As for the side effects, you know, some of the sleeping side effects can be affected by the timing of when the dexamethasone is taken. Some patients, it really activates them, and so they like to take it in the morning. Some patients actually have difficulty sleeping with it. And sometimes they take it when they go to bed so that it kicks in later. Sometimes the dexamethasone kicks in right away. Sometimes those sensory neural things takes a bit longer. So I have I'd say a third of my patients take the dexamethasone at night so they can sleep through it, and others take it in the morning. Regarding some of those other side effects, you know, especially in 2021, an important conversation, you know, with your doctor about dosing, that we've been using a lot of the same dosing of dexamethasone over the decades. And COVID is really, you know, it's been an opportunity for us to reflect on how much dex we really need to give patients. And so really having a conversation about the dosing of dex and decreasing the dose if you can, I think is really important.
Okay, thank you, thank you. And we have questions still popping in, and I'm sorry that we won't be able to get to all of your questions, but we're gonna take it offline. We're gonna do our best to get answers to some of those questions. So thank you for those. Thank you, Dr. Craig, you know, for being here and answering those questions. I certainly appreciate your participation and interaction in this event. I do have to admit, I do miss seeing all of your faces. So hopefully I'll get to see you guys next month there. Our next African-American Myeloma Chapter event is going to be on April 29th at 1 p.m. Central. And we're going to be speaking about how to talk to your family about your cancer diagnosis. I know that was something that I struggled with when my cancer diagnosis came around. It's like, how do you tell them? What do you say? And things of that nature. So we're going to break out on that. We're going to talk about that next month, and I hope you can join us. You also may be interested in our upcoming events that we have within the myeloma community. This coming Friday, March 26th at 7 p.m. Eastern Time, the Relapsed Refractory Myeloma Patients Chapter will be meeting. And they're going to be talking about the new drug, melphalan. This event is going to be an exciting one. And the doctors who had hands-on experience with this drug in the clinical trials can tell us how to give us hope to relapse and refractory myeloma patients. On Tuesday, March 30th at 1 p.m. Eastern Time, the Nutrition and Wellness Chapter is going to be meeting, and they'll be discussing benefits of plant-based eating above and below the belt with Jane Esselstyn. She's a registered nurse. So Jane, I apologize if I butchered your last name. Jane is the daughter of a renowned cardiologist. She's more interested in finding out the health of the entire body. So you want to come and learn how everything from headaches to sexual wellness can be improved through nutrition. And then lastly, Thursday, April 1st, Eastern Time, the stem cell transplant chapter is going to have their launch meeting. I'm excited about this chapter. So many people have questions about stem cell transplants, and it's time to gather together as patients to share what we wish we would have known for the next generation of myeloma patients. So thanks again to our sponsors, AbbVie, Bristol Myers Squibb, Amgen Oncology, Genentech, Karyopharm, Oncopeptides, Adaptive Biotechnologies, Takeda Oncology. So thank you so much for helping us build a strong myeloma community. We appreciate you so much. And until next month. Bye, everybody. Thank you so much, Dr. Cole.
Thank you. Take care, everybody.
Bye-bye.